Good afternoon, everyone. It's my pleasure to welcome you to our webinar, The Pit Stop Community Health Education and Drug Checking. My name is Ella, and I'm pleased to be welcoming Anna McCrea and Meagan Jonker, our speakers for today. This webinar is taking place on May 21st, 2025. We're recording the webinar today so that we can share it with people who are not able to attend. This webinar is organized by the Manitoba HIV-STBBI Collective Impact Network. This is a network of innovators working collaboratively to transform the landscape of HIV and STBBIs in Manitoba. We bring people together to tackle complex HIV and STBBI systems barriers, and we seek systems change by shifting the conditions that are holding the problems in place. I'm speaking to you today from Treaty 1, Winnipeg, Manitoba. We acknowledge that we work and gather on the original lands of the Anishinaabe, Ojibwe, Cree, Oji-Cree, Dakota, Lakota, Inuit, and Dene peoples, and on the homeland of the Métis Nation. We are humbly working together toward the Truth and Reconciliation Commission's calls for action and the Missing and Murdered Indigenous Women and Girls Inquiry's calls for justice through our research, events, and projects of the Manitoba HIV-STBBI Collective Impact Network. If you would like to find out more about the Collective Impact Network, sign up to receive our newsletter, or find our social media and YouTube page, you can do so at cinetwork.ca. This webinar is part of our ongoing efforts to provide education, and you can find past resources on our YouTube page. We will have a question and answer period after the presentation today, so I ask that you type your questions in the Q&A feature, and you can type a question at any time. However, we'll be answering those questions at the end of the session. So it's my pleasure to welcome Anna and Meagan today. We're very happy to have you and very interested to hear about the work that you've been doing. Anna and Meagan are health education facilitators and drug checking technicians and work in the Pit Stop, which is a program of 9 circles. Anna, who uses she, they pronouns, has an extensive background in coordinating safer space and harm reduction initiatives at local music festivals, and holds a BA in Sociology from the University of Winnipeg. Meagan, who uses she, her pronouns, has worked and volunteered in recovery and community outreach programs and currently sits on the board of the local chapter of Recovery Dharma. Both Anna and Meagan bring a wealth of experience and passion for harm reduction and are thrilled for an opportunity to share about their work. And we're very happy to have you today, Anna and Meagan, so I'll let you take it away.
Yeah, thanks so much, Ella. Welcome again, everyone, to our webinar. So we've already gone over a little bit about what today's going to be, but Anna, if you want to move forward to, just kind of reintroducing ourselves. So together as a team, we have about 12 years of experience in harm reduction. The drug checking technician training out of BCCSU has probably over 90 hours of training in that. So that's what we bring to the table, but we'll tell you a bit more about that in this webinar. So we'll just go over the quick agenda so you folks know what we're going to get into. But we'll give a brief overview of what you can receive for care and what you can expect to see when you come to 9 Circles, and specifically the Pit Stop. We'll talk about HIV in Manitoba specifically, as well as the toxic drugs, toxic drug crisis, harm reduction, and drug checking. And with that, I'll pass it off to Anna.
Awesome. Hi, everyone. Happy to be here. So to start off, I'll give a brief overview of 9 Circles Community Health Center itself, and then segue into kind of our work in the Pit Stop. So 9 Circles has been a community health center in West Broadway since 2001. It's a kind of a conglomeration of a few local community health centers that were born from the AIDS crisis in the 80s and 90s. We provide HIV and STBBI, as in sexually transmitted and bloodborne infection testing, treatment, and prevention for at-risk communities. We're also the home of the Manitoba HIV program, which focuses on HIV research, advocacy, and a lot of client engagement. We offer an integrated primary healthcare model for people living with HIV. So our clients of our primary care clinic, they have in-house access to services that include their doctors, nurses, pharmacists, dietitian, social work, et cetera, et cetera. We offer this comprehensive and holistic healthcare model to support the client engagement and their overall wellness. So the story of Nine Circles is the story of HIV in Manitoba. From its inception in the early 2000s, we can see that while HIV numbers have been on the rise steadily since the AIDS crisis of the 80s, we have seen a very sharp uptick in cases and new diagnoses in the past 5 or so years. What we're seeing now is unfortunately up to a 240% increase in the past 6 years. And what's very alarming is how Manitoba's HIV incidents are at least 5 times higher, likely higher than that than the rest of Canada. So I know that graph might be a little hard to see, but the spike there at the end is why we do this work in the pit stop. Another concerning and unique aspect of HIV in Manitoba is the different demographics of new HIV infections. While in the 80s, the AIDS crisis was predominantly affecting gay men and gay, bisexual, and queer men who have sex with men, the demographics of people that are getting infected today are much different. And those groups also face intersecting barriers and, pardon me, and marginalization. We can see on this graph provided by the Manitoba HIV program that now half of cases are affecting women. Majority are impacting people who self-identify as Indigenous, as well as people who use drugs and people who experience houselessness and homelessness. We see drug use is very common for folks with HIV, and it is both a frequent source of transmission and just a comorbid status of some of the people infected. From these numbers and from learning about this, the Manitoba HIV program, among others, it had an initiative or had a list of calls to action to improve HIV care and treatment and prevention in Manitoba. And one of those is to expand harm reduction strategies for people at risk and living with HIV in Manitoba. And thus, that is kind of the birth story of the pit stop that was added on and expanded from Nine Circles in the last 5 or 6 years or so. And that's where Meagan and I work out of.
Yeah, thanks, Anna. So, yeah, the pit stop has been around for a little bit. It's had quite a few changes in whether that's how we offer services, how many, like the staffing complement we have, the actual physical structure design. The pit stops had a lot of changes, a lot of upgrades over the years, and it just seems to be working better and better. But essentially, what folks can expect out of the pit stop. So, um, while it is open to anyone who would like to access supplies or a snack there or whatever, the idea is that it's a low barrier harm reduction kind of hub for folks who are at risk of HIV or STBBI infections, as well as other negative impacts like the toxic drug crisis, the overdoses, drug poisonings, etc. So we offer quite a bit of things. You can see there's like a little graphic there with some of the things that we provide. We also try and help folks out with whether it's like a tarp for their tent or lots of resource navigation. Of course, we can't do and meet every need out of the pit stop, but we do our best to connect folks to the great wealth of resources that we have here in Winnipeg, a lot of which can be found in the West Broadway area, which is really great. And yeah, typical client demographic, while we don't have folks divulge their demographics, we can see that there is for sure a lot of folks who come through who are people who use drugs, street involved people or unhoused people, adults of all ages, newcomers, complex poverty, things of that nature. So that's the ideal folks that we're hoping to help. Unfortunately, there's different detriments to accessing health and social services for folks, and so we're hoping to kind of take away some of those barriers where we can. But overall, the idea of the kind of birth of the pit stop was to really aid in prevention of HIV cases, as well as just providing more testing and wellness initiatives for folks. So, yeah, we can go to the next slide if we like. So yeah, there's again, like beyond the services that we kind of can, hand to hand for folks, we also have a lot of things that we do off the side of the desk, so to speak. So we have our pit stop desk as well as just across the way from us, I guess, in the same space as the pit stop nurse. So they are able to provide drop-in nursing to folks who access the pit stop with an ideal to help folks get some low barrier STBBI testing done. We have a cultural support worker. Again, our round room, so our cultural support space is very much just it's 2 steps away from the pit stop desk. So very accessible and front and center for folks. We've got a safer bathroom. So that's a public bathroom open to whomever needs it, which is really helpful to folks in even though we're in an area with a lot of businesses and restaurants and such, there's not typically a space where folks can have a public bathroom that's, a single stall and they can kind of have some space to themselves. So that's been really good in helping folks feel safe and supported. We've got a huge network of overdose prevention, whether it be the the training that Anna and I provide to anyone who wants to do a training on how to use the injection naloxone kits, as well as we have, response teams for if there's an overdose or folks, just kind of starting to maybe get towards that point that we can have our nurses respond to. And yeah, at the end of the day, just like really try to cultivate a lot of connection. So that often happens out of recreation, which we have, we're building more and more, but we have quite a bit of groups that we do out of our gathering place. Again, very much in eyesight of the pit stop. And yeah, through those connections and recreations, we can find it easier to facilitate health education to folks and build that relationship and have them trust us if we are trying to give them, some sort of information about things that they might want to know more about. Oh, and just to brag, we serve approximately 150 clients every day, and that's been um, a number that's just been rising. So whether that's that there is a rise in need, or that it's just that folks feel safe and supported when they access the pit stop, and so they're telling their friends and family and loved ones about us, and they're also coming in, adding to the community that accesses it. I assume it's a bit of both, probably, but yeah, it's definitely been doing well in that we're seeing more and more people every day. So how do we do all these things? Some of the things that make it work for sure is consistency, right? Like policies can be for sure a barrier to folks. It can be a hard thing to try and communicate in a way that doesn't feel um, like we're expecting people to kind of push boundaries. So a lot of that messaging really helps in just having signs we can reference or, just really repeating the basics across the board to whomever may come in so that everyone has the same expectations, and that we can also expect to, as staff, to have treat everyone with the same level of expectation for accessing the pit stop. What else? Yeah, just transparency within the policies. If anyone ever has any questions or, wishes to kind of um, challenge, so to speak, the idea behind, the reason for the rule, that kind of thing, we're always open to having our management team or our executive director sit down and chat with folks more. And beyond that, we have, the option to fill out a survey online, or yeah, lots of options for feedback for folks, and really trying to build that environment collaboratively with the people who access it. So, but the reason for policies and expectations is always for like the end of the day, we do it for safety. So, so that all folks can feel safe in there. And the huge ambassadors for safety within our space are 100% the community hosts, which we currently have 2 people in that role full time, which is amazing, I think, for community members to be able to. I think a lot of the times in these type of frontline spaces, these kind of like, not that we're a drop-in space, but a place where folks can come in on more of a walk-in basis. There tends to be a lot of different people and different faces to see, and so by having consistent people that they can expect to see, and get their supplies or their snack or whatever from, I think really helps people to um, build that trust more, and kind of know what they can expect out of their day. So Anna and I are also upfront, but we have, right now we're not, right? We're in the webinar. So by having consistent folks at the front to greet people, I think is a huge piece that can go a long way. And I mean, beyond safety of the people in the role, we also have so much safety built into the physical design of the pit stop. For example, our desk is situated directly across from the safer public bathroom. And so we're able to visually see as folks are going in and out. We can keep an eye on, we have like timered lights. So if it's been more than 10 minutes, we know to check out on someone and just make sure that they're still doing all right. So yeah, all those little tips and tricks that we've built into the design really makes the workflow easier for everybody. And yeah, building relationships with clients and also other community organizations. So they're the clients that we typically see have a multitude of needs, and unfortunately, we can't meet all those needs in one space, but we can do what we can to connect folks to other resources, or even bring those resources in. So we were, for example, seeing a very big need for housing support. And while it's not something that we do here necessarily for like on a walk-in basis, folks who are primary care clinic clients do have access to those resources, like through their social worker, for example. But for just anyone coming in from the West Broadway area, we have brought in a partner organization, Sarah Riel. So we have a staff come in there once a week, and she's been very helpful to our community. So yeah, building those relationships and doing that warm handoff, so to speak. So but at the end of the day, it all works with, we have, great staffing complement outside of like the folks who work directly in the pit stop, as well as the nurses who pass through, the occupational therapists, the pharmacists, whoever. And we've got an amazing volunteer crew that super happy to be here, does a lot of the more maybe mundane tasks, that and also is another joyful face for folks coming in. And then 100% the peer advisory group is a piece of the puzzle that really makes it work by being able to check in with them and kind of guide our initiatives of asking them truthfully, like, is this something that would benefit you? If not, why? And so they've been really great in making sure that we can keep with um, the mindset of nothing about us without us. So that's yeah, that's Not all of how we do it, but that's a lot of how we do it.
Yeah, Megan, I'm glad you highlighted so much how much our community hosts and especially our peer advisors are so essential to pulling off what we do, especially as you said, we keep getting busier and busier. And uh, as some days can feel a bit chaotic, but it's actually, I think it's really incredible that we are really successful in this work, and people feel safe and return, and we still love our jobs every day. And yeah, like this network you talk about is it's how it's all possible. So I will jump in now to talk about not the how we do it, but the why we do this work. I know we've talked a lot about the changing demographics of HIV, and as well as the intersecting harms from the drug crisis and all these systemic and structural barriers that the people who are most at risk for HIV and STBBI are also experiencing. So as Megan outlined, like the function of the pit stop in our whole department is prevention and testing and wellness. And it's in recognition of this really the incredible network of services available to folks in our primary care clinic for people living with HIV. We would love to be able to provide more resources for folks before they get to that point. And being a safe place and a culturally appropriate and a consistent resource to support people to make informed choices to keep themselves safe and to avoid HIV and other STBBI. And again, in line with the toxic drug crisis that we've been experiencing, us and across Canada and elsewhere in the world, the very basic premise of life sustaining, that the harms people are up against, people who use drugs every day are facing more and more danger and risk, and hoping to provide these life sustaining interventions for folks to implement into their own lives and to empower them to make choices that keep them safe and well. Um, And that, yeah, I guess brings to my point to destigmatizing. We know very well in all of our research about HIV and other STBBI that stigma is one of the most dangerous factors. It's one of the biggest like challenges to person like mental wellness, spiritual and physical wellness. It's also a massive barrier for folks to engage with prevention services like testing, and to engage with harm reduction and health education to learn how they can best protect themselves. We've can form communities of people who are living with HIV, and just like our peers, people who use drugs as well and have STBBIs and experience with that we can create these spaces for community where people feel accepted and actually for once in the majority, and connect over their mutual experiences and learn from one another and mostly teach us a lot. We are learning from our folks so much. In terms of our health equity and social justice, I think those two are very similar. We truly don't just do this work just to treat or prevent HIV. I know that across the board in the organization, we do this because it's the right thing to do. It's a just and equitable thing to do because the communities that are most at risk for HIV have historically and still today face persistent systemic barriers, structural barriers to their happiness, health, and well-being. A lot of our folks sit at a really complicated intersection of being racialized, living in complex poverty. Many experience comorbid physical and mental health conditions. And so we are seeking to, in essence, decolonize healthcare and empower people by being like fiercely patient-centered and low barrier and as close to no barrier as we can, and incorporate culturally safe and considerate practices throughout all the work we do. And all this, yeah, we really want to decolonize healthcare is to empower individuals to have the tools necessary to self-determine their health and wellness, for their own well-being, rather than, just as I said, like not just to prevent HIV, which is like our original, our baseline mandate. And the reason why we do this work in the pit stop, truly, I remember when I first started there, and as our role as a health educator, and we're at the desk and we're handing out pipes and needles and juice boxes in these brief interactions, considering how do we provide health education, both in these brief interactions, but also for so many folks that come and go. And the realization that the only way to provide harm reduction and health education is via avenues of trust, and we need relationships. And so the pit stop in all these various services, and styles that we provide, it is in effect to allow us to create the relationships necessary so that we can provide that. Because without those relationships, as I always say, then really who am I? Then just a person with a juice box and a bubble pipe. So we're really fortunate that we have all these various avenues that we can really form relationships. And like Meagan said, a lot of our clientele are regulars, many of them daily, sometimes multiple times a day. And so we really get to know folks, and figure out what works for them, and that we have the trust to give them education. And again, like, we are learning so much from them at the same time, and having their influence and input on both our policies, but our knowledge about the world. Our clients are so profoundly wise that these relationships, it's truly like a mutually beneficial and ongoing thing. Next. So zooming in kind of away from the grand whys and the hows and stuff, bringing back to the nuts and bolts of it, is seeing, at the same time, while HIV is on a really concerning rise, there is also, as I mentioned, across Canada, the toxic drug crisis. The drug supply has only becomes more volatile every single day. And we have a really, really devastating amount of deaths from toxic drugs, drug poisonings and overdoses. In comparison to our population, Manitoba is unfortunately leading the pack for how many of our loved ones and our relatives that we lose every day to toxic drugs. And we are hoping to, again, meet folks at this intersection and do our best to equip them with the knowledge and resources and tools to stay safe in this increasingly dangerous time, for people who use drugs. As I say, we love people who use drugs. So this brings us to our very, very exciting new initiative that is, I think a lot of folks are interested and excited to hear about, maybe just us because we're big old drug nerds. But Meagan and I have had the pleasure to now be drug checking technicians with the use of a very snazzy machine. We were graciously donated or provided this machine from the Manitoba government as it's part of their strategy to reduce harms of the toxic drug supply. We're really honored to have their support and their buy-in on this, their endorsement and recognition of the current situation we're at, and really grateful for having another tool in our toolbox to equip our folks to prevent harms. The whole point, the drug checking, is we are really trying to allow people to make informed decisions about their drugs so they can use them more safely, because that's the problem with illicit substances, is them being unregulated, is their contents are unknown. And while I can go to the store and I can buy a 27% bottle of alcohol, or even my cigarettes, I know were made in a controlled way. Folks that use drugs that have been deemed illegal don't have that luxury. And as the supply changes so much, all the strategies that they adopt to keep themselves safe every day continue to like the goalposts on that keep getting moved. And so we are trying to both teach and inform clients individually about what samples, like about the drugs they have in their possession, but also we're really wanting to learn about the local drug supply across Canada. It's the illicit drug supply has a very like regional trends that we can see, and we're hoping that this helps us form a network of knowledge to understand the local drug market and even predict and respond to trends in the local supply. I'm 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 sure many of you have seen before the drug alerts that get circulated through safer sites operated by Sunshine House, as well as through Street Connections. I think these drug alerts are an absolutely essential tool to help keep communities informed about what's going on in the supply. Um, whether it being bad batches or, I mean, it's all bad batches, but or new and novel analogs. Like we know fentanyl has been increasingly a concern over the past 5+ years. And where then the fear was fentanyl would be in a drug. Now fentanyl is almost ubiquitous across the supply. And people that use opiates, fentanyl is in most of them. And then so the people's strategies to approach their consumption and usage is tailored to that. However, then new and even more dangerous and powerful analogs coming out, analogs being either chemically or like in effect similar drugs, but often much, much more powerful. Same things, benzodiazepines, forms of depressants, sedatives, things that different substances that have a compounding effect that greatly and drastically increases the risk for the user.
Okay, so thanks, Anna, for giving us the lowdown. Ongoing toxic drug crisis, overdose crisis. And so, yeah, more about drug checking. So there's a lovely little picture of the FTIR spectrometer, or as we call the machine that we have, we call her Gertie. So Gertie is our spectrometer. Just to quickly summarize it, it uses an infrared light and probably magic. I tried to understand the science. I understand how it
I think it's laser beams.
yeah, definitely laser beams and unicorns, but so it uses the infrared light to like shoot laser beams through there's like a crystal and we just need like the tiniest little sample of a drug, like we often reference it to like the size of like a match head. So like just the tip of a match, that's all we need to analyze samples. And yeah, it compares those spectra files, like the reading that it gets against other files that are saved in the libraries. So a lot of the work to cultivate these libraries has been done out of BC, as they, have um, led the pack a lot in the realm of drug checking, as well as unfortunately in a lot of the toxic drug crisis. Likely, again, like Anna said, with the different supply being a lot more regional, it's likely that BC has a lot of more of the complex issues with the supply constantly changing, just given their location being off the coast and closer to, being able to get things from the States and things like that. So um, we then um, use the machine to read the spectras. We also have kind of more of a quality control with our drug checking strips. So I have one right here. Show you. These are the strips. So these are fentanyl test strips. Good old blurry cameras really helping me out right now. And so those can, we dissolve a very finite amount of the drug in water, and similar to like a urine drug screening, It acts the same for seeing if that compound is in the liquid. And yeah, the checks are typically quite fast. The readings happen quickly. It just comes down to quite a bit of interpretation on our end, depending on what the drug sample tends to be. So, for example, we see a lot of what is colloquially called down, which is typically a mixture of different fentanyl analogs and fillers. Increasingly more so within this last year, it's now typically you would see a fentanyl and a benzodiazepine, which is really adds to the complexity of potential overdose, especially because naloxone or Narcan does not work on benzos. So things to just be aware about, and to be able to tell our folks who, again, like Anna mentioned, doesn't have the luxury of being able to walk into a store and ask um, the salesperson, like, what are the expected effects of this, and what's the potency, and all those things. So really trying to give our folks a better general idea of what they might be getting into. And of course, always coming back to, different harm reduction messaging, and reminding folks, of the basics. Don't use alone if you can. Start low, go slow, all those good things. Um, and yeah, service is free, confidential, it's legal, because of our exemption, which our supervisor worked very tirelessly to get the federal exemption, which I believe we got on New Year's Eve of last year, which was pretty cool because that was taking a really long time. But yeah, so feds make you jump through some hoops for having illicit substances in a building. That checks out. But we got there. And so now folks can come in here legally, get their stuff checked out, and have some good chats about harm reduction. So we do collect some of the basic data from every check and share those with Street Connections and Sunshine House to learn more about their trends. So for the folks who don't know, Street Connections and Sunshine House are the only other two places that in Manitoba, actually. These places are specifically in Winnipeg, but in Manitoba that currently have a drug checking machine that we know about, used for greater health messaging. So we stay connected with those folks to just add to our community practice, and really build on, again, like Anna said, the trends for our area and our folks. I think we can pop to the next slide if you like, Anna. So yeah, how does it work? There are some challenges, limitations to having an FTIR. We have seen really amazing things out of Sunshine House with them, like really walking so that we could run. They raised a butt ton of money to get a very expensive machine. The machine is quite expensive. It's also quite delicate. Like I said, tiny little crystal. So and many moving parts. So it requires very much calibration, all those things. So yeah, very much a piece of machinery that is to be respected. It also requires quite extensive training to really feel confident in how to interpret the spectra files. So the machine's really great about always wanting to give you an answer. That being said, it's still a computer, so it does require some of that kind of human interpretation of being realistic about what we've brought in, and the best match, and even for our vision to be able to find different peaks that aren't matching and isolate those and reference those. So we got our training through the BC Center for Substance Use, and they are currently the only really ones offering like an official training platform for that. So we're really grateful that they were able to come and give us that training. Again, it requires that legal exemption from the Government of Canada. And yeah, just it's time resource intensive compared to not being able to offer this. It does, take quite a bit to even the conversations of telling folks before they come in the room, like what's to be expected. As much as we can say, yeah, it's legal to have your drugs in here. If we don't have that relationship with folks, it makes sense that folks would be reluctant to trust that. And there's a lot of different reasons for that, but I think that stigma, internalized stigma, or just, general valid wariness of the system, I think all plays a part. So, yeah, it does take time to, I think, build that relationship, but we've been seeing, in the short time that we've kind of had this service open, we have been seeing a lot of response from the community, which is awesome. And at the end of the day, it does have limited detection. So some of the things that we always tell folks, the technical word is heterogeneity. I said that wrong, but I always just say it's the chocolate chip cookie effect. So if you have a chunk of meth or down or whatever, and it's got chocolate chips throughout it, so those would be referenced as like different maybe concentrations of the drug, or maybe different drugs altogether. And so one of the things that we always start with is asking folks that we can crush up the whole substance, mix it all together so that we can get the best reading. We also, again, use the drug checking strips to do um, a double check, but also the Spectra files, it does have a limit till about 5 to even sometimes upwards of 10% of what it can find. And the strips actually work on a much lower threshold. So they are able to find things in much lower concentration. And typically, if it's a fentanyl or a benzo, you only 1 to 2% of a benzo concentration can and will likely have a very strong reaction in folks. Same with fentanyl, especially depending on what the fentanyl analog is. So, like carfentanil being 100 times stronger than typically on average than our standard fentanyl HCl, would yeah be something to be concerned about that we wouldn't be able to find on our machine. Um, and so I find that can be frustrating for folks, myself included, because we do want to be able to use technology to find out exactly what we need. But that being said, it is ends up being a really good opportunity to have more conversations with folks about different harm reduction measures and different spaces, and what we want to build towards for creating that ideal space for folks to be able to use their drugs more safely. And so at the end of the day, a supervised consumption site would be very ideal. In Winnipeg specifically, we are working towards, or not we as in Nine Circles, but the healthcare system is working towards getting one of those set up. So hopefully that will be there for folks soon, so that there is a space where they can test their drugs and then also use their drugs. So yeah, there's so much more I could say about drug checking, but I'm just trying to be mindful of time. So I will pass it off to Anna, but keep any questions in mind if you have anything.
Awesome. Wow. Yeah, man. You nailed it there. And it's not too like we don't want to discourage anyone or even ourselves with the challenges and limitations. I think going into it, especially being on the front line of the toxic drug crisis, there's this hope that this would be kind of this like silver bullet solution. And unfortunately, the drug supply is always feels like it's a half step ahead of us, and so it can't find everything in it. um, but we've been educated, and we lean on a really amazing network of resources and knowledge to be able to triangulate the results best we can. But what we've really learned in practice of doing this work, it's not just about seeing what's in a given drug sample and informing that client. What like the real magic of what drug checking can offer in frontline harm reduction settings like this is this rare and like really unique opportunity to connect privately with our folks. Our drug checking room is a private room with a closed door. It's quiet. We have some time. There's usually like some hands-on stuff, finicky stuff that we're doing, and we can just like chat with folks. And it's been really amazing, even folks that we see like every day, every other day. The quality of the interaction, the relationship that develops in that space is really incredible. And we are like truly learning so much from them, because people who use drugs and have these intersectional barriers are truly experts of their own lives and are really wise in keeping themselves safe. Um, it gives us this opportunity to learn about folks, about like their unique and diverse needs, and find out how we can best support them, in ways that we aren't able to do just across the desk. And I know we're getting close for time, but I feel just to like wrap up that point, I really want to briefly tell a short story about a drug check we did recently, that I think really like encapsulates that moment. It's a client came in to the pit stop who accesses supplies fairly regularly. We always have good chats, good laughs, and everything. They requested test strips, take-home test strips, which we happy to provide, but then offered, hey, we got this new drug checking service. Do you want to check it out? And she said, yep, came in. As I'm setting up the machine, she is a little tired, and she discloses that she had been sleeping, she had been unhoused for a few days. She had lost access to the place she was staying. She had just survived domestic violence, and yeah, it was just kind of keeping on the move for a few days. Throughout the drug check, we had found, she gave me a sample of crack cocaine. We tested it. I found it was in fact not crack, but meth. And then we realized, well, that's probably why you haven't slept in a few days. But then we had a discussion about how to be unhoused and identify as female is really dangerous. And so we talked about how she shared how not sleeping is a safety measure, which absolutely fair. Then I was able to ask if she ever accesses any shelters, and she says she doesn't feel safe at the typical shelters, also very fair. And I was like, hey, did you know that there's some both domestic violence shelters and gender exclusive spaces if you didn't feel safe being in mixed gender spaces? And she didn't know that, and she was really interested to hear more. And so as we wrapped up the check, I connected her with our community host, who is really incredible, who has a lot of history in supporting victims of domestic violence and unhoused women. We also connected her with a cultural support worker. So if you want to pop in for a smudge quick or just hang with Auntie for a bit. And then while she did that, I went and grabbed her a tent and a sleeping bag and tossed in a little extra juice and sent her on her way with resources and the next steps to getting her sheltered in the meantime. And I think that was really like this moment of all the things that can happen when we're just able to connect with folks. And just because the drug she brought in wasn't the drug she thought it was, um, we both learned a lot about ways that she can either adjust her approach to it or in ways that it's serving her or not serving her in the meantime. And yeah, that's kind of what I meant about the magic. It really like it put the sparkle in the air of like, now this is really what it's all about.
Thanks so much, Anna. That's a great way to wrap it up.
Yeah,
And
so it
with
brings
that,
us to the end.
yeah, we'll get into, I can see some questions there. I don't know if you want to rattle them off for us, Ella.
Yeah, I'd love that. Thank you so much, Megan and Anna. That was a great presentation. For our attendees that are in the room right now, I've posted in the chat a link to our survey. If you have a minute to fill out the survey, we really appreciate it. I know that we're always asked to provide feedback, and it can be a bit taxing. This feedback helps us to improve our webinars and continue to receive funding. So we'd love it if you have a minute to fill it out. We do have some great questions. The first question here first is a shout out. Hi, I love this program. Thanks so much. Can you please expand on the nurse drop-in STBBI testing a bit? Is the nurse there on set days or hours? Do they proactively engage, offer people testing, or wait for them to request testing? And then the other question in this kind of two-part question is, can you please share any experiences around offering testing for bacterial sexually transmitted infections as opposed to viral infections like HIV and Hep C?
Yeah, I could speak to either point of that. Megan, I don't know if there was a part of that that you wanted to speak to.
Yeah, I think we could both talk all day about the pit stop nurse, and how great, specifically it's a she right now who's in there, but that role in general is really amazing to have. But Anna, if you want to go off about her.
Yeah, I think as Megan was talking earlier about the physical design and the infrastructure of the pit stop itself, one of the best things about it is that right across from the desk is the nurse's room. And whenever she's not with a patient, her door is open. And if she's not charting, then she's behind the desk with us. And so she's able to, I mean, people say, hey, could I get some bandages for a wound? And she's like, what sort of wound? Or folks are talking about some questions. She's really incredible at kind of peeping in and be like, hey, I am a nurse. I would be happy to help you as much as I can. She is limited in the service she can do beyond the STBBI and reproductive care. But as is our mandate for STBBI prevention, she is more than happy. She's very gung-ho to provide full panel testing for folks. We are very fortunate being attached to a primary care clinic, that we do have a lab in the building. So we don't have to send people out to a Dynacare or anything like that. So we are able to do full serology and urinalysis screenings on folks, swabs and stuff as needed. So then folks are able to get the results faster, and we have a lot of creative ways to get results to folks that might not have a phone or address or anything like that. I'd say most of the folks that end up visiting her for one reason end up connecting with her for various other things, and she's really creative about and great about connecting folks with the resources that what they need.
Yeah, and if I could just top off that too, like, so it is like when I think about what I would love to be able to offer the community, I would love to have drop-in STBBI testing for all folks. I believe before my time, but also before the HIV epidemic spike in numbers, whatever you want to name it, came, the Nine Circles was able to provide walk-in testing to just whomever wanted it. So our pit stop nurse is specifically there for folks who access things at the pit stop, whether that be a snack, harm reduction, that kind of thing. So there is that kind of um, I guess, barrier, so to speak, for folks accessing. So if somebody comes in and they're not a regular and they aren't really asking for anything else from the pit stop, we do redirect them to other spaces in the community where there is drop-in testing available. And beyond the drop-in STBBI testing that the pit stop nurse offers, she also offers PEP and pregnancy tests and minor wound care assessments, which can be, again, like a great benefit to folks who have a harder time accessing healthcare for whatever reason, but also a great conduit to make folks feel comfortable to getting something that they might feel deem as stigmatizing, like an STBBI test.
Thanks so much for that great answer. We have another question here. Simply, how many clients come through your doors each week? If you could estimate a
So
number.
yeah, so estimated number, we are open Monday to Friday. A good ballpark of what we see is, 150 more or less. Yesterday we were upwards of just under 200 folks that we saw, likely because of being closed, long weekend and other spaces being closed. But yeah, it's kind of hard to get a hard and fast number, but I'd say 150 folks a day is a good bet. So I don't know, math, that's like 10,000 people a minute. We see a lot of people every day.
Yeah, and this is only like folks coming into the pit stop in particular. It's the same people coming through the same door to go down to our primary care clinic. That's a whole nother large group of people that also come and serve. And there's definitely crossover, like a huge amount of crossover too. Um, So there's far more than that walk through our door and are on property and engaging with our programs, like our recreational and our cultural support programs, drug checking services and stuff like that. I do know that when I started 2 years ago, we were less than half as busy. And I think that those numbers have been steadily trending upwards. And like Meagan spoke about earlier, who knows if that's representing the growing and increasing needs of community. We also, I think, like to believe that maybe we're doing something right and folks feel safe coming and bringing their friends and stuff. And that's really cool and we're worth it on the extra busy days.
Thank you so much. One more question here in the Q&A. If you do come across a bad supply of drugs or a particularly bad supply, do you report it? What happens for further harm reduction when something like that comes across your desk?
Yeah, thank you for asking that really great question. Yeah, I think so. So when we talk about a um, bad supply, or it is hard to contextualize, being that on all unregulated drugs, unfortunately, have their unsafety and their risks to them. So a lot of the times we would deem a bad drug check as either, like Anna's example from the story, that it's not the intended drug that they purchased. It could also be, we did have one scenario where it was a person who would use this certain drug of choice quite often, and found that this particular batch had hit them very hard for a seasoned user. And so we were able to test that with the machine. Unfortunately, again, like, so, fast forward to the actual analysis, we couldn't necessarily see all of the picture on the FTIR, and we were trying to figure it out based on, so a lot of the times, yeah, it is based on, has this person used this drug before? Was there an adverse reaction, like whether it's a seizure, an overdose, just kind of feeling it heavy. And so we again collaborated with other organizations, kind of chatted about, have you seen this stuff? We do, specifically, our building is building a connection with the Drug Analysis Systems Canada. So they have what they call a mass spectrometer, which is like a huge laboratory which can see a lot more that we can with our smaller machine. So Straight Connections actually wasn't able to get off a portion of the same sample to this drug analysis service, where they were able to find there was a much stronger fentanyl analog. There was also a benzo in there, and there was also ketamine in there, which was something we hadn't typically seen before. And so it was really well explained to me one time that in these combination drugs, it's not a fentanyl plus a benzo plus ketamine. It's fentanyl times a benzo times ketamine. Like, it really exacerbates the effects, and the potential for overdose. So there is, and so from that, there was a drug alert that was made through Safer Sites, which is based out of Sunshine House, and they're a great resource for finding drug alerts. But also there was one made through Street Connections, like on behalf of the Canada Health, like drug analysis services. I think that's captured kind of the bulk of it, but I'm sure Anna has something to say as well.
Yeah, there's two aspects. When we find something, it could be, I mean, there's been examples. It's not that we found something concerning, it's we didn't find what we thought we would. Um, and those are times where we would send a small sample to the confirmatory labs, the drug analysis services, and have better equipped labs analyze a substance. However, if we might not be able to do that, or we are actually very confident with our analysis and we think we have the necessary info, this is when we would engage with the community of practice between other drug checking sites and attend and talk about it, share the results, and then form a plan if we think that there's really immediate health risks from using that substance. And then we would trigger a drug alert, either through Street Connections or Safer Sites. hopefully both, to disseminate that rapidly throughout the community. If there is something we find concerning, because the main goal with the drug alerts is not so much of just like a bad batch as in like you got sold bunk, but like the immediate risks and harms to life and safety.
Thank you so much. We have one more question here, which will be our last question, as we're at 2 o'clock now. But this is a really good question. I think it's a nice way to end off our webinar today. So this person says that this work is a long time coming. The public and political will has been against it. What can we do, or any of us do here in the webinar today, to help with destigmatizing work to keep these sorts of efforts ongoing and sustained?
Oh, I love that.
I do love that.
Thank you for asking that. Yeah,
Destigmatize all parts of harm reduction, I'd say. Carry
Yeah.
naloxone loudly and proudly. Ask your friends if they know where they get their substances. Shout it from the rooftops, everything from seatbelts to now legalized marijuana and stuff, and talk about and compare it to the illicit drug supply, and just try to normalize it in our day-to-day conversations, to start like to talk to our neighbors and our families, our parents, and our communities that might not be familiar.
Yeah, I'll speak for myself in that, like, I mentioned at the beginning of this webinar, having like a background in recovery, and so much of recovery has recognized and really utilized harm reduction as a piece of recovery, but there is still a lot of resistance to that, and confusion, and upset, and so I always try, and if I find that people are either backing away or feeling challenged, or whatever it may be, I'll try and be gentle and compassionate in my approach, but really kind of ask, like, well, why do you think like that? Or why do you think we shouldn't, why do you think it's not okay to talk about, you know, STBBIs here, or drug use, or whatever it is, right? And just, you know, who kind of, like, where did that come from? Was that something that you feel strongly about, or is that something that you feel like is the polite thing to do? Because who is that being polite to at the end of the day, when folks are feeling like they can't talk about things, and so now they're having to make decisions in the dark without you know, the wisdom of their community behind them. And so I think that a lot can happen in uncomfortable conversations, and I know a lot of people don't really want to have that. But then again, like Anna said, you know, it could just be something more visible, like having a visible naloxone kit on you, and things of that nature, or a really cool t-shirt like Anna has that you can get at Manitoba Harm Reduction Network.
Yeah, and I guess the final point is, because these harm reduction initiatives, such as supervised consumption and our drug checking and things like that, there is an aspect that involves community consultation, where decision makers and stakeholders and neighbors get together and hear the proposition and share their concerns. I think it's really important for people from all sides to engage with those. Even if you are like, you want to see more harm reduction services in your community, it's also okay to ask questions, and to talk it out about potential things that could result from increasing the services. Because I think that means that we're going to do these things right, do them as best we can in order to make them sustainable and effective. And I think the naysayers can feel really loud. So I think to join the voice of the people that really endorse this work and want to see more of it in their communities, yeah, it goes a really long way.
Fantastic. Well, thank you so much, Meagan and Anna. It was wonderful to have you today. And I know we all really appreciate the information that you shared and the good work that you do every single day. So a great thank you to you. And I hope you have a lovely rest of your week. And thank you everyone for joining us. And I hope you as well have a lovely rest of your week. Yeah, thank you so much.
Thank you
Thank
so
you,
much for
Ella.
being here, Molly. Thanks everyone for being here.